This is a Beggy Sisa podcast.
We don't do abortions on pregnancies that are unwanted just because people were having one-night stands. Many of our abortions are actually being done and requested by married couples.
The right to a safe legal abortion became a reality in South Africa in 1996 when the Choice on Termination of Pregnancy Act became law. Until 3 months into a pregnancy, anyone in the country can have an abortion without having to provide a specific reason for it. For a pregnancy between 13 and 20 weeks, women can get legal abortions for special reasons, such as financial circumstances or if the pregnancy will affect the woman's mental health. After 20 weeks, a legal abortion can still be performed, but only if there's a serious threat to the life of the pregnant woman or if the fetus has congenital problems. Tlaleng Mofokeng is a well-known South African doctor and also a United Nations Special Rapporteur on the right to health. She's also a Catholic, but believes a safe abortion is a human right. She regularly performs terminations of pregnancy herself. I recently caught up with Tlaleng at a meeting in New York and asked her why she thinks that.
Abortion is a human right because firstly, it is a medical procedure that is well researched, that is appropriate when people do not want to be pregnant anymore up to 20 weeks of gestation. And it's a human right because people have a right to access timeous, dignified health care. The right to health in the United Nations definition encompasses also social determinants of health. So the fact that someone wants an abortion in order for them to still continue with their education or go back into work and earn a living or play sport or relocate, people have rights to freedom. People have rights to occupation and education. So abortion is a human right because access to it enables and unlocks access to so many other human rights.
There's lots of studies that show safe abortion saves lives. It improves maternal health. Can you break that down for us?
We have to think about abortions as being safe or unsafe because abortions happen, even the ones that are spontaneous, that are naturally happening without being induced. I always like to start from that framing. Therefore, then, when you intervene and offer a safe abortion by a trained healthcare worker within a health facility, you are absolutely contributing to better outcomes in terms of maternal health. Because when there is no access, people who are pregnant will find a way to have an abortion. And this is where unsafe abortion providers, the street pill sellers, people who are using social media, or people who are using health facilities that do not have adequate, for example, the pills required for the abortion or the instruments required for the manual vacuum aspiration. Those abortions that are unsafe can lead to some complications, heavy bleeding, continuous bleeding, some infections, some perforations of the uterus. And what we are saying is a safer abortion is good for the people who are pregnant, but a safer abortion is also good for the management of the budget and the health system's resources because it's much economically. Research has also shown that abortion is not just only safe and one of the simplest procedures, but it's also cost effective. So rather than governments waiting to respond to complications of unsafe abortions, because they will happen, rather focus your efforts on increasing access to safe abortions where people can get an abortion first time around and be guaranteed that the quality of that abortion will be safe and complete.
In South Africa, we have legal abortions and we have worked to make it safe, but we still see so many of those things that you've mentioned now. Ads on poles for illegal abortions, and we still see unsafe abortions. Why is that?
The right to health demands and places an obligation on states to have a national health plan and a policy that supports the plan and budgeting. What you have in South Africa is one part of that equation. You have a policy. It's good that it's there because we know that the right to abortion is always contested. So the protection in law to have an abortion is very, very good. Where we are failing is that we are not training enough healthcare workers, and that lack of actual healthcare providers who are trained means that we have more demand than people who can assist. So no matter how well-meaning you are, there will always be people who are unable to get access to abortion because there are not enough doctors and nurses who can provide it. So we need to focus on making sure that the undergraduate program, the curriculum, covers as well the human rights aspects of abortion. Key principles such as non-discrimination, equality, dignity, privacy, right, confidentiality are very, very important for people who are seeking abortions. And I proudly tell people that I'm an abortion provider to try and deal with that issue of stigma, that I can be an abortion provider, I can be a UN special rapporteur, I can be all of these things. There's no contradiction in my principles or in my morals or in what I stand for just because I give and support people who need abortions. The other thing I think that the government should be doing is actually really seriously having specialized units that are going to deal with the people who are selling pills on the streets, on social media. People who want abortions are desperate, and people take that vulnerability and monetize it and take advantage of people. The other thing, which is really a health system issue, is that we need enough commodities. We need generic medications in South Africa. Right now, if you need to use the pill that, is the first step of a medical abortion, it's an imported pill. It's very expensive. 3 pills costs close to 4,000 rand now. With the exchange rate of the rand to the euro and the dollar, you can imagine how much that box of pills cost.
So if you want a medical abortion in South Africa, do you need all 3 pills? In other words, just the pills will cost you 4,000 rands.
So as a healthcare provider who runs a clinic, from my suppliers, that's how much I'm paying. So in order to do a successful abortion, you need a combination of pills. You need the first pill, which is the most expensive one, which stops the growth hormone. Then you follow with 4 pills that will actually then itself start the bleeding process and the cramping that people often will experience. If you then require a manual vacuum aspiration, that only happens once the pill have been given. So everyone, regardless of whether you have a manual vacuum aspiration or not, the abortion starts with medical pills. That's why I'm a fierce advocate for changing the language around medical versus surgical. There's no surgical intervention per se.
Can you just explain what is the difference between a medical and a surgical abortion, and when do you get which one?
So a medical abortion is an abortion that is started and completed by the use of medication only, the pills. And research has shown that medical abortion, the pills only regimen, works in a pregnancy of less than 12 weeks. Beyond 12 weeks, you then have a higher risk that the products of conception may not all of them fully be evacuated from the uterus just by the pills. And therefore, we have this manual vacuum aspiration, which is basically a suction unit. It doesn't get plugged into the wall. It's just a manual suction unit that is then used to empty and literally just suck out, and using the vacuum process to suck out whatever products are left in the uterus. That would be a surgical abortion. It also starts with the pills. You have to make sure that the uterus is soft, that the pregnancy hormones have been blocked, and that the bleeding can start and has started by using the other 4 medicines. The difference is that a surgical abortion can be done all the way up to 20 weeks in South Africa, up to 24 weeks with particular strict clauses and requirements that people need to meet, and that you end the abortion with a manual vacuum aspiration, whereas a medical abortion, it starts and ends only with the pills being used.
You've spoken a lot about stigma when it comes to abortions now, and that you are a safe abortion provider and a proud one. So what do you tell people who say you're murdering babies?
I don't have time to even answer that because I am a medical expert and I went to school. I did embryology at school. I studied gynecology and I studied bioethics, and I am an expert in human rights and the right to health. I rather focus on giving information to people who may require abortions on how to know when you think you may be pregnant, how and where to go to confirm if you are pregnant, why it's important to seek help sooner rather than later, and what are the things you can expect. That kind of information and engagement I have all the time for, but not the other stuff, because it's arguments that have been used over and over again. It's exhausting. We have international human rights laws and standards. We have ethical standards in medicine. We have world federations and world bodies of gynecology who have for decades have been explaining what these issues are. And even as a Catholic, I can tell you now that people used to have abortions using indigenous health methods up until the stage of quickening. And quickening meant when you can feel the fetus starting to move. And that usually happens around the 24th week, right? So it's not coincidence that we are able to offer safe abortions up to the area of 24 weeks. So even this religious references, it's like it makes no sense, because even in those times, women were having abortions up to the point of quickening. We don't do abortions on pregnancies that are unwanted just because people were having one-night stands. Many of our abortions are actually being done and requested by married couples. Because life happens. People get retrenched. They have to relocate. They are stressed. They thought they wanted a pregnancy, and suddenly when it happens, it's like, actually, we can't do this, right? And even this stigma and this myth that abortions are just something that young, reckless girls do, it's incorrect. In many clinics, when we look at our demographics, many of them are not young, reckless girls. They are professional women who have career aspirations, and a pregnancy happened in a time where, it was inconvenient for her. And so contraceptions fail.
When someone comes to you as a patient and they're not sure they're pregnant and they're not sure whether they want to keep their baby, how do you counsel them?
I prefer the word fetus, because babies are born at term, and that's not my area. But what's important is, first and foremost, to acknowledge what the person is saying to you. I think a lot of the times when people come to seek an abortion, something has happened. There's always a behind the story, and that's where I would often like to start. What are the reasons that are making you feel so overwhelmed that you can't do this? Because a lot of them will tell you that I'm just so overwhelmed, or so much is happening. And it's to acknowledge that emotion. Some come and just say, I tested pregnant and I want an abortion. And they're very clear about it. So you have to gauge your patient and meet them emotionally where they're at. Sometimes it's couples. And there's a lot of sadness about it, because perhaps they went through their antenatal care and there are some severe, malformations of the fetus and congenital malformations which would be incompatible with life. And, their gynae would refer them to us, or some gynaes phone us for advice. And so it's a whole system approach depending on what the needs are. Some patients would have gone, for example, through intravenous fertilization, and they get pregnant, and then the relationship has broken down so much that they're in a process of divorce. That has happened. Those are like real life stories. The other important thing is to go through what to expect. A lot of anxiety for people around abortion is what they've read or what they've seen on YouTube or what they've been told. And one of their first things they say is, I want an abortion, but I'm so scared of the pain. And so it's to reassure them that we have a pain management protocol that we follow in the clinic. This idea that women don't feel pain, or the procedures that we do just feel like a bad period cramp. Like, it's rubbish, we need to change that. Often you will get a patient who says, I want the abortion now, today. We can help that person. Some say, thank you for the information. You've answered all their questions. And they say, we'll call you. And they call and they make an appointment. Some phone and say, thank you so much for the information. We actually want to do antenatal care now. Can you help us? We say, fabulous. Come. We do that as well. I have a good relationship with another gynae. So when some of my patients are giving birth and they have a cesarean, I go and assist in that cesarean. It's not just about abortions. Some patients choose antenatal care, and when it's time to give birth, often they will ask me to be there, and I come.
For the past few years, you've been a special rapporteur for the right to health at the United Nations. What does that mean, and what is the most meaningful lesson you've learned during this time about the right to health?
What the work involves is monitoring the situation on the right to health and its realization throughout the world, reporting to the United Nations Human Rights Council and General Assembly every year, conducting country visits to get first-hand exposure and analysis of a particular situation in a country officially. I can do consultations as well. I'm encouraged by the UN to do on expert panels and academia. And the most exciting, I suppose, something that has happened in this time is that through my work in human rights and international human rights law, I have been appointed a distinguished lecturer at Georgetown University, and I'll be working through the O'Neill Institute to really do an amazing project.
Lastly, what do you think is the biggest thing standing in our way to reach better health for everyone?
What I think is the one thing that's holding us back, especially for the right to health, but realizing true wellness, is that governments are focused on health systems and health facilities and not enough of an understanding of social determinants and commercial determinants of health. And what I mean by that is, for example, during COVID, people have been told to wash their hands regularly for 20 seconds. Where I come from in Qwaqwa, you don't even have safe drinking water to cook with and clean with and wash your clothes with. So when the message is wash your hands regularly for 20 seconds, with which water must that community wash their hands regularly for 20 seconds with? And when we say we want young women in science, technology and engineering and mathematics, and we celebrate them at varsity when they graduate, yet we are judging poor people for wanting a grant, for wanting social support. So how will that child who graduates and becomes a STEMI graduate, and we talk about gender equality and parity in science, how will her brain mature and grow if she's malnourished? So I feel that we are fixated on the outcomes and we are not doing enough in terms of inputting the correct and quality in order to get outcomes that are of quality. Very long answer, but ultimately the short answer is we need governments who are going to resource in the long term successfully programs that deal with underlying determinants of health, because we need those in order to get positive health outcomes.
That was Dr. Tlaleng Mofokeng, who is a United Nations Special Rapporteur on the right to health and a medical doctor in South Africa. Tlaleng specializes in reproductive and sexual health care. If you have feedback on this podcast, please email me at health@bekisisa.org. I'd love to hear from you. I'm Mia Malan. Thanks for joining me. Until next time, goodbye.
This was a Bekisisa podcast.